Every time you think healthcare in Nigeria, you think people quarreling with each other, pharmacists, doctors, junior staff, senior. I'm a management teacher, and this is the dysfunctional organization. You know, teams. I have a favorite writer around this gentleman called Patrick Lencioni, the dysfunctions of the team. Why is the healthcare system so apparently dysfunctional in terms of coordination of things and people working together as a team? So, Dr. Ejembi, you and then Mazi Samu Huabunwa on the same subject.
Okay, thank you very much for that. I think when you look at the coordination, first we
perhaps you can adjust your laptop also so we can see your face more. We're seeing more the area around you. Wonderful, thank you.
Okay. So when you talk about coordination, I think first and foremost, even constitutionally, when you look at the legal framework, we have problems. We are told health is on the concurrent list, even though some people argue whether it's on the concurrent list or not. So it's usually coordinating things across the 3 tiers of government has been very problematic. So let's start from there. Each layer of government, even if you formulate a policy at the national level, you cannot expect that all the states will buy in and begin to implement. And there's little control at the federal level to force states, to implement policies, no matter how good the policies are. So it's like we are running, is it 38 national health systems now? The federal one, the 36 states plus FCT. And if you add the layer of local government, everybody doing his own thing. So coordination has been a major problem. And there's been a lot of talk on how to improve coordination across the tiers of government. A solution has not been found. So it's frustrated implementation of policies. That's number one. Number two, even within the Federal Ministry of Health, there's little coordination across departments and across programs. Oftentimes, I say programs, they put concrete walls across themselves, especially programs that are well-resourced. There's little information sharing, and there's little integration, if at all. So for example, I'll give an example in the Federal Ministry of Health. You take reproductive health, where you look at safe motherhood, there is a division or whatever looking after that program. And then you find another unit looking after VVF, vesicovaginal fistula. And all of them, the same determinants. And the interventions are essentially, to prevent it are the same. But VVF people, that suffer complications from childbirth, and maternal self-motherhood are preventing maternal death and all of that. And maternal death is the end product. VVF people are not talking with maternal mortality or self-motherhood people. And they are planning around the same issues of prevention of maternal death and how to address backlog of cases. So these kind of things across programs, across departments, people are not talking. And when you now come across agencies, the National Primary Healthcare Development Agency, for example, that are responsible for at least implementation of PHC, and for the Federal Ministry of Health people, for policy. But you find them, taking over some implementation things, and there's a lot of tension. So these kind of things are frustrating program implementation or policy implementation. Then by the time you leave those levels, you now come to, within professional bodies. The tension there is out of this world. There's professional rivalry, there's all sorts of infighting. And by the time you look at it, it's even affecting patient care. Common example now, you go to a health facility like the teaching hospital that I know. Previously, when a doctor walks into the health the ward and goes to see the patient, the nurses all come, you do the round, you see the patients together, instructions are given, are taken, and everybody works towards implementation. Now the doctors come to do their rounds, the nurses are sitting at their station. They are not under doctors. The doctor wants to send a messenger or a lab ward attendant. They will say they are under the nurses and not the doctors. And at the end of the day, it's the patient that suffers. Even if you want to get a screen to shield the patient, it's the patient's relative that will go and bring it. The nurses are sitting looking at you. So that kind of professional tension and rivalry, it's adversely affecting the quality of care that we offer the patients. It's also affecting, I think, the collective visioning and working together to achieve our goals and objectives.
Now, the people who have overcome these problems elsewhere, I mean, obviously, they don't have 10 heads. How did they overcome them, and why are we not applying the same things that have led to better coordination?
I think, for example, in terms of overcoming the problems, for example, let's say Ghana, their health indices are a lot better than ours. And it's because they have a single government health system. We don't have state governments implementing their own policies, local governments doing whatever they want. You have a single health system, and you plan centrally, and you can ensure implementation up to the local level. So is it possible to have a constitutional amendment so that we have a unified healthcare system, not the kind of healthcare system that we have?
Okay, we'll come back to that, but I want Mazi Samuwa to come in here. I mean, and this is at several levels. The problems of pharmacists, doctors exist, but it's even many years ago, I wrote a case study on the essential drugs list. When Professor Oligwe Ransom Kuti was minister, we all know what happened with the World Health Organization's EDL, the concept of generics being available in government hospitals. And I recall very clearly that the way it was interpreted literally led to the folding up of the pharmaceutical industry as we know it in Nigeria. I wrote that case study more than 20-something years ago. Mazi, are you still there?
Very much there.
Oh, okay, please. Coordination, what's the challenge? What's the problem?
Look, Pat, as we are discussing all this, my heart continues to bleed. I feel like crying because just like Professor Lambo said, he's older than maybe slightly older than us, and he thinks he has spoken enough and he's tired. We also should be tired of speaking. When Dr. Menakanya came to government as Minister of Health, one of the things he did was to empanel a team. We came from people like the late Professor Lebute, Professor Akinkube, myself, and many others very distinct, to sit down to work out a system and a plan that can work or that could work. But no sooner than things changed, policies kept changing, or even where the policies were made, they were not being implemented. But let me go to the main issue you asked me. I think there are three things dealing with coordination. Number one, which is number two and number three, if you look at it, is lack of leadership. Lack of leadership it's the issue that we face. Because all the problems Dr. Ejembi has spoken, all that we have spoken, it just shows there's no leadership. National, subnational, tertiary, there is no leadership. These are symptoms. But you say those who did it somewhere, do they have 8 heads? They don't have 8 heads. The critical thing is that they have leadership. The problem is leadership. I mean, leaders can do good, they can do bad. So if we have good leaders, they do good things. If we have bad leaders, they do bad things. So leadership is an issue, and that is where the whole thing hinges. There is no reason that we should be the way we are if we had good leaders to coordinate and to work out a system that works. So that's the primary thing, lack of good leadership at different levels. Now, when we have had some smarting of coordination, you find that the leadership shown, and that's the next problem. The next problem is lack of team spirit. Lack of team spirit. And this was caused, with due respect to everybody listening here, when Professor Liko Iransampiti came, with all the good things he did, he was the one who dismembered the unity of the healthcare team. When I became a pharmacist, an intern pharmacist, I entered the teaching hospital, and my colleagues who were house officers were 1 or 2 steps ahead of me in the hospital in terms of grading, financial grading, salary, and allowances. In fact, at one time, I was leading both the medical doctors, physiotherapists, and all of us to go and meet with the director of administration to present our case. We were united. There was no schism, there was no division, there was, like Oliko Iransampiti came, one of the good things he did a lot of good things in primary healthcare, but he took out doctors and put them on a different scale and kept the rest of the health team in another scale. That's when this saw the foundation of this disunity came on board. Today, it has almost become a policy that every health institution must be headed by a doctor. So I'm 40 years or 42 years old pharmacist. In practice, I come to the hospital or any health institution, and my son, who just graduated in medicine 3-4 years ago, is posted to that place. He becomes my boss. That is absolute injustice. And that's why the nurses, the physiotherapists, the medical lab scientists, and all of that rejected it. And that's the major thing. If we don't call it the name, we cannot solve it. Medicine or healthcare is a teamwork. In the university, sometimes we all start with the same basic training, and then we begin to differentiate, to different specialties and special areas. We need to bring that spirit. We need to bring that spirit. And what did I call you? What did I mention Professor Lambo to you, Pat, when we were discussing this program? I said he was a non-health, he was not a medical doctor who headed the ministry. And he managed the ministry differently. So we need to differentiate administration and management from clinical practice or from specialties of healthcare. Those days, there used to be a director of administration who handled administration in hospital, and then the different professional groups had their leadership. I think we need to restore to that. If not, the competition will continue, and the unhappiness by some segments who feel they are maligned. You come to a hospital, chief medical director is a doctor. The medical advisory is a doctor. Everything is weighed against other healthcare professionals. That is a principal issue. Thirdly, is poor regulation. The poor regulation is due to lack of regulation. I mean, the poor regulation is manifesting in what was said even by Dr. Menakanya, where you have all kinds of quacks and people crossing lanes, people practicing as if they were doctors, people practicing as if they were pharmacists, people practicing as if they were other healthcare professionals. Sometimes it's the healthcare professionals themselves crossing lines. Sometimes it's people from outside who have no training. Now, all these things are man-made. They can be regulated. If a pharmacist practices like a doctor, a medical doctor, he should be fined. If a doctor practices like a pharmacist, he should be fined, except where there is insufficient manpower. Then they do what they call task shifting. You can ask a doctor to do more or less, a pharmacist to do more or less, but it's with understanding that this is for the benefit of the patient. It's not each person usurping the other's responsibility in a way that is uncoordinated. These are the issues, and these issues are not beyond human solution.
Well, thank you very much. I think it's very important to get to this so that we can begin to engage at the level of solution.